I prefer to get a bit closer because over the next couple of days hopefully we're all going to get very close in terms of dealing with things. It's fantastic to be here, and I recognise a lot of people in the audience and some old friends here. So I'm going to talk about a bit about Track C and something about Track B that comes out of Paris in 2017. And if you go on the web, we have all these IAS toolkits where there are slides. And in fact, if you go to the conference, you can download a lot of the slides and watch lots of the presentations. So we do that so that the whole world can actually, when someone says, hey, what about this presentation at IAS, you can at least have some idea yourself of what that looked like. Okay. So, self-testing. In the UK, you can go into a pharmacy and you can buy a test and you can self-test. And if you're negative, it has promotional about how to keep safe. And if you're positive, it tells you where you have to go and connects you with a clinic. So this is from the USA. And what they did was, it's called eStamp. And it was online provision of self-testing to MSM. And they tried to get men who've not really tested before, right? And the idea is that if you have to go to clinics all the time to get tested, some people don't want to do that. They want to test privately. And there may be many reasons. And they randomized the study, and they recruited these people online. They needed 2,500 people, and what they said was, we'll give 4 self-testing kits in the mail, and the access to the usual services, versus just saying to people, have usual services. We're not giving you kits. If you want to get a test, you know where to go. Okay, so they were looking at what the added benefit of self-testing kits were. Well, interestingly, of all these MSM in the study, 17% of the MSM had never previously tested. You might think that's a small number. I think that's a huge number of MSM that's never had an HIV test before. I think that's a big number. And tested at least 3 times in 12 months. People who had the kits tested 3 times in 12 months, 79% of the time, and people who just had to go to clinics or other places only 22% of them tested 3 times. So you can see actually people were testing themselves more regularly if they were given the home kits. And new linkages, new HIV diagnosis is here, 22 versus 11. And it was interesting that men who had never previously tested, look at that, they actually tested 70% versus 7. So the kits not only made you test more, but it made you test if you've never tested before. Because if you've never tested before and you're in a study, maybe you don't go to the clinic still. You just don't. Well, you can see they didn't. Whereas if you got the kit, okay, I'll give it a go. And they found 22 versus 11. And the interesting thing was, the linkage to care looked a bit less in people with home kits, but it wasn't statistically significant. But that is something to be interesting. You test at home, you're positive, yet you don't go to a clinic. Whereas if you test in a clinic, of course, you're linked immediately. So, although it's not statistics, there's something to think about in that. And there was another study, a community organisation in the UK, encourages MSMs to order self-test kits. And what's happened is, in the UK, it really is a big user satisfaction. MSMs really like the service. They really want to do it and engage. And you can see that 92% of the men that test at home in the UK are actually going to a clinic or being linked into care. So it seems to me from this message, and okay, it's the USA and the UK, it's not Latin America, I agree with that, but it's something to think about in terms of increasing the amount of testing we do, rather than being reactive to people coming to clinics, being proactive and saying, hey, you can have these kits. Obviously, then money comes into it, and who's paying for them. But I think for every HIV positive person you diagnose or get in treatment, that is a big saving globally. So that was that. And more self-testing from the UK, and these were delivered online to MSM, and we have a lot of migrants, black Africans, and they're very hard to engage. They tend not to come to clinics, they tend not to come to see doctors about HIV, and we ordered nearly 5,000 kits, And 3,000 out of the people, 62% told us of their result. Again, 19% of these MSM and black Africans had never had an HIV test before. And about 40% had tested more than a year ago. So if you look at these high-risk people, they're not testing. A lot of them aren't testing. Whereas if you send them kits, they will do it. So this is an advantage. 24 were positive, all were MSM, and we made contact with 92% of them. And most of the people who responded to a survey said they liked the service, they'd use it again, it encouraged them to test, and they were happy for the support they received. So the reason we did the survey was, if somebody says, oh, you did just something and they just joined in and they were sort of like passive subjects. No, they really felt it was a good thing to do, to be in the study and to have self-testing. So I know there are lots of different cultures around the world and they're very different in the way they respond, but it doesn't mean you can't deliver self-testing kits in a Latin American context. So I think that's very interesting. Now, the other big question that came about was, we knew from a lot of the heterosexual studies that if one partner who was HIV positive was undetectable, they couldn't transmit it to their other partner. And most of the data came out of heterosexual studies. So one of the things that was looked at in Paris was, what about in MSMs who are not using condoms and around anal sex? If you're undetectable on treatment, can you transmit by anal sex? Of course, we all believe from some of the data that you wouldn't, and especially when we look at the heterosexual data, we also think you wouldn't, but the study was done to look specifically at this. 591 couple years of follow-up, 343 couples had 16,889 sexual acts. I'm always amazed how they collect all of this data. I mean, people must keep a good diary of what's going on. Okay. Yeah, okay. Was it yesterday or the day before? Oh, okay. But it's fantastic that they do. And HIV positive partners, now it's interestingly, they use a 200 cutoff, right? During 98% of the follow-up. So almost all of the HIV positives, almost all of the time, were basically undetectable. We know it's hard to transmit below 1,000 copies, so below 200 is not a bad thing to do. No new infections which were genetically linked to the main partner were seen. In other words, if you're an undetectable HIV positive MSM having anal sex with your partner who's HIV negative MSM, it appears you don't transmit. I mean, we can never say never in the world, but it's approaching zero. And it's interesting that there were 3 new infections, but they were from outside the partnership. We saw this in the heterosexuals, we see this in the MSMs. I mean, I always say, we have a town in Newcastle, in Britain. It's a beautiful town actually, but only go in the summer because it's always cold and raining. And 10% of the children born in a big survey there did not belong to the father. Okay, so when you see these results, we don't, outside partnership, we just it's normal. It's actually normal human behaviour for these things to happen. Okay, so and again. It's good that they said provide strong support that undetectable prevents transmission. Okay, so PrEP being rolled out. So all these yellow countries have some form of PrEP programming, and I'm sure since 2017, Paris, it's getting more now. Okay, so you can see here in Latin America this big swathe across Latin America where PrEP's available. The UK, although it's available, we're still not funded by the government for it. And what we really think is not just what the government want to do with it, it's what your local at-risk populations, how they want to deal with PrEP, how they want to take with PrEP, how they want to access PrEP. All of this stuff needs to be worked out in all the countries where PrEP is, because I don't think one model of providing PrEP is going to work. You really need to know your key populations, how they're going to access it, how they're going to want to take it. It's all very different. But we need to scale it up. And my belief is that treatment won't end the epidemic, but you have to link it with prevention. And I'll give 3 examples. Swaziland, with circumcision in nearly 3/4 of the men. In Uganda, where circumcision's gone massively up. And in Britain, and especially in my town, London, where the introduction of PrEP has reduced massively the number of new cases. So increased testing, put people on treatment. I'm not saying that's wrong at all, that's absolutely right. But without some really key prevention strategy being linked in, I don't think we're going to end the epidemic very easily. Okay, what about on demand? So epidemic was the French study where you took 2 pills at the beginning and you took them every day until you finished to have sex, and you took another pill and you finished. And you can see this group of men, they took this group of men having infrequent sex. Okay, so I'm not going to say what that is because everybody has their own definition what infrequent sex is. Okay. Median pill use, 9.5 pills a month, covering 5 sex acts a month. So that's 5 a month, they call that infrequent sex. And the HIV incidence was 0 in the people taking the pills versus 9.3 in the placebo arm. Okay. On-demand PrEP's adequate alternative to daily PrEP. So it's really interesting. We know in the high-risk MSM, intermittent PrEP worked, but they took, on average, 14 out of 28 days they took PrEP. These people having infrequent sex are using 9.5 pills, which is probably about 1 week of it total. So it's really interesting that another way of giving PrEP to people, for example, people who go in and out of sex work. A lot of sex workers aren't doing sex work every day. They're doing it for a while, then they go back to their homes and families and do other stuff, and then they go back into sex work. While they're doing it, this sort of PrEP would be useful. Or for example, we have guys who go to sex parties at the weekend. And so for them again, taking it over the weekend, preparing themselves against HIV, another useful. And I think the 2 big studies, the PROUD study showing daily PrEP reduced it by 88%, and epidemic, which was marvellous in terms of intermittent, has given us some a way of taking PrEP. Again, culturally, it may be that some people like to take pills every day, and others don't mind taking it when the occasion comes about. And in France, they've had a big implementation project. 3,500 people were taking PrEP. 97% were MSM. All of them were high risk of acquiring HIV. 60% nearly used on demand, 40% daily regimen. And they've had 4 HIV infections, 2 detected during the first weeks of PrEP, and 2 after stopping PrEP. I'm just going to pause on this. The first week of PrEP, maybe they were already getting infected when they took the pills, and when they stop PrEP, they're at risk again. So anyway, it's really interesting how if we could get PrEP around the world, and it doesn't have to be pills, as I say, circumcision and other ways of using prevention are all good. Now, what about reasons to choose PrEP or daily? So this is a study in Dutch men. Why do I want to use daily PrEP? Why do I want to use event-driven PrEP? Well, some people are worried about taking their pills. I need a daily structure. I like to take them every day. I can't think about taking... Okay, so this is what I'm saying about tailoring the PrEP to the patients and not just saying, this is what you have to do. Some people go, I can't plan my sex. I'm walking around, I go to a club, I'm having sex, I haven't got time to take 2, so I'd rather take them every day. What about the side effects? I don't like taking it intermittently because I think I might get side effects every time I take it. Rather than if I take it every day, I'll get side effects that I'll wear off and I won't get any more. They think by having a break, then any side effects will come back again. They'll come back again. And you can see here, and some people are scared of resistance. In these people, event-driven, I don't want to take things every day. I don't like taking things every day, I might have problems. I plan my sex. I've got a low frequency of HIV risk, so I don't want to take... Why should I take pills for a month when I'm only having sex 5 times a month and I can just take them for 9 days? And I don't want to take a whole load of pills because they might be poisonous. Okay, that's all. So you can see here that actually the groups divide into 2. I'm sure there's many in the middle, but it's really... And you can move, you could move from one to the other. You could easily in your life over years go from one, I take them every day, to now I'm going to take them intermittently. Okay, so the good thing is the choice is there. And we have to be aware of this, I think, in any PrEP campaign, that people are going to take things differently. And what about adolescents? Well, we know the data from South Africa that the highest risk people in Southern Africa are young adolescent girls. The problem is that they have sex with elder men because the older men give them things. They give them money, they give them gifts, they give them some form of status. I'm with an older man, but they also give them HIV. And then as the girls grow up, they meet a partner of their same age and transmit the HIV to that man. And that man then gets a young girl, and it just keeps going round and round and round. So adolescents and PrEP, most of these were females here, you can see here, 15 to 19 years old, and it was reasonably well tolerated. It's just really asking about adherence. Now this is the problem. Week 12, 57% had detectable tenofovir, and week 48, only 38%. And the adolescents complained of side effects or perceived side effects. So although they're keen on taking it and would like to take it, they don't keep taking it. Over time, they stop for some of these reasons. And some of these reasons are around side effects. And there may be other reasons they haven't told researchers. Because, as you know, for those of you who have had or have got or are about to get adolescent children, the conversation with them is always a little around the edges and not often very direct. Okay, so if we're going to give PrEP to adolescents, we have to do more research and find out the best way of delivering it to them, something that they want to do. So one way is, of course, injections. So long-acting. And there are two things coming now. One is this long-acting integrated inhibitor cabotegravir, and you can see here the problem is injection site pain, right? So if you want to have protection, that's the problem. 34%. If you took this big dose, if you took the smaller dose, you don't get much. And headache with the bigger dose. So people are now saying, well, every 2 months you could have an injection of, it's about 2 to 4 mils of cabotegravir. So, okay, they're going to investigate this now. So every 2 months you have an injection, forget about it for 2 months. So for some populations that's fantastic, for others they might want to take pills, but that's coming. And the next thing that's happening here is that this very, very long-acting Merck compound, and long-acting rilpivirine, and you could put these two together. Some people think it's going to be 4 or 6 monthly, and you might know the Gates Foundation have given a huge amount of money to a company in California that developed devices that release drugs for malaria, for TB, you can imagine, and for HIV. So imagine having an implant in, right, which would protect you against HIV for 6 months. But obviously there are problems with that. If you get problems, you have to take it out, and you have to turn up at 6 months. Otherwise, the drug levels will be going down and down and down. If you get HIV when your drug levels are low, you could get resistance. So there is another option for us, and they're not far away. I don't believe these implantable things are too many years in the distance now. So they are something very interesting. A little bit about differentiated service delivery. What this is that it basically says, how can we deliver HIV care to 40 million people in the world in the current model? Big clinics, big doctors, big nurses, big pharmacists, right? And they all come to us, and then they all collect their pills, and in some countries you have to come every month. So this is not a model that's sustainable for anybody. So we in the IAS have got this differentiated care model where basically we set up in rural areas and in other places people who are undetectable and well, they come and collect their drugs. If the government say they have to do it every 1 or 2 months, they come on every 2 months. Otherwise they can come every 6 months. And once a year they go to the clinic. Once a year they can go and visit. Or if they get sick. Now this model, we've been doing this in the UK for a while. We call it home delivery, where people get their drugs delivered. They have a blood test, and that can be done locally, but because we have a big network of clinics, you can just go there and have it. But in Africa now, this is really becoming a huge model of care. Either the drugs are delivered to them, or the sickest person in the group goes to town and picks up the drugs. Why the sickest person? Because he needs to see the doctor. And then he brings them back. And I think that in Latin America, you've got things going on, but I think that more and more, especially where you've got difficult access, you have mountains and you have a lot of forests, right? Both of those are difficult access. I know that we've been talking to Unitate about, and they do delivery of drugs by drones, right? So, and delivery of the blood tests the other way. So you put the drone, you fill the drone with the drugs, you take it to a very difficult place to get to, like up in the mountain, and then you put all the guys who've had their blood test, they're all put inside, and they're all sent down the mountain in the return drone. Now you all may laugh, but that is a wonderful use of technology, right? So all you need is that one healthcare worker up there, and the lab and the clinic down there, and we ought to do more of that. I'm just going to now, I've just really said that, we need to evolve our public health approach to new models. So finally, I'm just going to talk a little bit about reducing stigma, because it's a real, whatever people say, I know we're all in HIV and AIDS, and we realise it goes on, but it's one of the biggest barriers for absolutely everything. It's a huge barrier for prevention, it's a huge barrier for treatment, it's a huge barrier actually for normal social function. Because even within a family, if one member's hiding stuff from the others because of stigma, that is destructive to any family structure. So we really need to have to think this. And in Senegal, they've been doing a lot of work with peer-led community groups, training of healthcare workers, peer-to-peer anonymous referral systems to the health services. So I can refer someone without them knowing it's me that sent the person in. And they've really been reducing the amount of stigma. And I think that this is something that we don't invest enough work and money in. I know that activist groups do, they do a huge amount, but I think that the whole healthcare structure, if we can get PrEP and treatment and access done, we still need to work a lot on stigma and in our own cultures what that means. So stigma-free services to female sex workers. Imagine the difficulties in many countries female sex workers have in getting any sorts of access to healthcare. In some countries in the world, you could be punished by death if you're a sex worker. So it's a difficult issue. So, and they have come through a lot of principles. Accept each sex worker as a human being. Don't ask unnecessary or intrusive questions. Because curiosity for human beings, when I worked in a prison, I never asked any of the prisoners why they were there. Right? That was not my business. My business was to provide them with healthcare work. Sometimes they told me, and of course they were all innocent, but that's fine. I don't have to make a judgment whether they are or not. The Lord does that. What I have to make a judgment about is their health. And it's the same here, right? And so, in this service they got 90% retention of the people coming back to their service. We need to do more in all of our clinics to address this and to make sure that we have a stigma. I don't think it'll ever be stigma-free, but very, our tolerance to stigma should be zero, and we should try and achieve a world where people feel very calm about coming to get healthcare and not scared. So I'll leave it with that. Thanks, Liz. I'll hand over to you.